Ufficiale dell'Ordine al Merito della Repubblica Italiana. Grazie, John. Thank you for having joined us on Radio Italia Uno. Delighted to talk about this recognition and your story, professional and personal.
Buongiorno a tutti. Where would you like me to start?
Okay, well, let's start. I've had a little bit of a look at your research background. So let's start. So professor in medicine, cardiology in particular, and I come across this term, coronary vasomotor disorders, which is one of your specialties. Guessing, I would say it's something to do with the arteries and how the heart move.
That's right. So just in terms of background, I work both in the university and the hospitals. I have a combined position. So that means my role is that I do research, which is an important part, but I also teach medical students. And then, of course, I also look after patients. And for me, it's the combination of the three that I think I'm very, very lucky to have those, because one helps the other, so that they're all very important. In terms of the research, there's two broad areas that I work. So one is, as you said, this coronary vasomotor disorders, which are difficult. So what it is that people usually, when they have heart attacks and when they have chest pain, the worry is that they have blocks in the arteries of their heart, the coronary arteries. And so we have very good treatments. We have balloon treatments. We have bypass surgery when they have that. But the thing that's interesting is that some people get exactly the same pain and can also have heart attacks, but they have no blockages. And so a lot of times what happens is that these are overlooked and say, well, there can't be anything wrong with them because there's no blockages there. But the blockages can come from spasm in the arteries and also problems in the microscopic blood vessels. And this is something that's intrigued me for many, many years. So this dates back to the 90s while I was still studying in cardiology. And I really had the fortune of working with one of the gurus in this area, who was a Professor Attilio Mazzari. And so I worked with him at Gemelli. So at the time, he was the Pope's cardiologist, but he was an absolutely brilliant man that I had the opportunity to work with. And so he was considered sort of the father of this coronary artery spasm. And then he then sent me to Japan. So I spent time in Japan because the Japanese have a lot of this spasm. And one of the studies that we did was comparing the spasm in the arteries, the Japanese compared to the Italians. And what we found was that the Japanese were much more likely to get spasm than what the Italians were, which was an interesting thing.
Well, actually, as you were saying that, you just prompted a little thing. I didn't realize you'd done that work at Gemelli. And I was assuming that maybe the Japanese have a low incidence of heart disease. I don't know that.
But no, you're right.
Yeah, and the Italians or Southern Italians used to have a low incidence. I don't know if they still do. And that's where this whole Mediterranean diet thing started, from observations around Naples. What's the story around that?
Okay, so what you're talking about is where you get the cholesterol blockages. So if you like, the standard sort of heart problems. And you're quite correct in many of the things that you said. So to put it in perspective, if you look per 100,000 of population, the incidence of having heart attacks from cholesterol blockages, then you start very high. The people that are right at the top there are like the Russians, and the Scots, they have a very high incidence. Then you come down to America, Australia, which is about 110 per 100,000. Then you come down to the Italians, which are about 80. And then you come down to the Japanese, which are 28. So that gives you, so that's where you have cholesterol blockages. But that's different to what we're looking at, because this is no blockages, but you develop spasm. And the Japanese much more likely to have that problem. And my professor, Professor Mazzari, he he said that it was just curious that all the Japanese found a lot of this problem, and yet it was thought to be more common in Italy than in other places, but that was because he was very fastidious in studying it. The Americans referred to it as Pisa angina because he found so many cases, but they had trouble finding cases. But now it's taken many, many years, but now finally it's starting to catch up and people are appreciating because we're testing for it much more often, whereas before we seldom used to test for this condition. And that's part of it is so spasm in the large arteries, but also problems in the microscopic blood vessels. And that's particularly common in women that we see that. And so, again, the problem is that the standard tests don't show it. So you need to do special tests where we measure blood flow in the heart to be able to diagnose these conditions. So as I said, I was very fortunate in my career having a number of very good mentors and, having the opportunity to work at Gemelli and also in Japan. It's been a great, very fortunate with that.
So how far have we progressed with this? You were just talking about the testing for it rather than understanding or curing or treating.
So one of the things that we've done is that we formed a group called Covardis, which is a group of international researchers, cardiologists, dedicated in studying this condition. And so we have representatives from Italy, from America, from the UK, from Germany, all working towards this. And so we've made significant inroads because we've increased the awareness. We've now improved the diagnosis, but you need to diagnose it before you can treat it. And so we're starting to do a number of studies to start to look at, what's the best treatment. With some of it, we've always had a clue as to what is some good treatment, but particularly with the microscopic blood vessel problems, we need to do a lot of research. And that's where I'm trying to spend a lot more time now doing this research work to try and find treatments for people with these conditions. Because some of these people get lots and lots of chest pain, and it's frustrating to try to treat them.
Okay, it's so many points you bring up here. I don't think we're going to have enough time to look at them all. So two things I want to look at. So the international collaborations and also what you talked about creating databases. I see you're involved quite a bit in that. And why is it important to have databases?
Yes, so that, as I said, one focus of research is trying to understand this condition. So a condition that you can't actually see, have trouble visualizing, but is clearly there, and patients are disabled. The other part that I do is when people come to hospital with just a standard heart attack, no heart attacks should be standard, but a standard heart attack, do we treat them efficiently? And so one of the reason that we need these databases is to monitor for complications, because just about everybody who has a heart attack has one of these, as we call it, invasive tests, where basically you're putting tubes into their wrist, up into their heart, and injecting dye to see if they've got any blockages that we talked about, the cholesterol blockages. And then if we find them, we do the balloon treatments. But the problem is that doing this test, the dye can be toxic to the kidneys. And also we have to give lots of blood thinners, and so that people can bleed. So we need to monitor to make sure that we are not having too many of these complications. And some of the ways that we've helped in this area with these databases is that we've worked out the particular risk for a patient, because as you can imagine, if you've got a very young person as compared with an elderly person having this test, the kidneys are not quite as good in the elderly person. And so what we do is highlight to the cardiologist, this is their risk of having a kidney complication from the dye, and you should try and limit the amount of dye you give to this particular dose. And so that helps the cardiologist. And what we've shown with this program is that we've reduced the risk of bleeding complications, we've reduced the risk of kidney complications. And then what was really remarkable is that we reduced the risk of having another heart attack in the month after you left hospital. And that's because we made sure that people went home on the right tablets and that. So that's where these databases are particularly important and pivotal, because we need those to be able to monitor that and see what's actually happening with the patients in just our routine care.
Yeah, yeah. So you were talking about the international collaborations, Italy, yes, Germany, Japan, United States. What differences do you find across these countries? Are they mostly cultural, the focus of health research, or others?
I really enjoy meeting with my international colleagues. So we established this group 15 years ago now, and we work closely together. But a lot of the cultural stereotypes, the Germans are very precise. It's either black or it's white. Italians, of course, it's always grey. And it's interesting to work with different people from different cultures, and just the way that they approach the same problem I found very interesting. And it's been very fruitful, because having that blend really helps us advance the science. So it's very good.
Now, you've mentioned already women, there's something specific about women. There's another avenue, in a path I think I've noticed in your research, and that is the rural versus urban divide. What's specific there?
Yes, so that comes from going back to the database work you were talking about and the heart attacks. So what happens when you're in Adelaide is that if you have a heart attack, and particularly like if it's a big heart attack, then immediately you'll have one of these angiogram tests. If it's 2 o'clock in the morning, they call in the whole team and we do one of these procedures. The problem is that if you are in rural Australia, if you're more than an hour and a half away from the city, then it's going to be too late by the time we get you down to Adelaide and do this procedure. This is for the big heart attacks, so that we have to give them a drug that will open up the artery, and then we bring them down to have this angiogram test. So that's some of the things that we're also monitoring with this database and seeing, how can we improve this?
Yeah, and every now and then I get surprised to hear or to see that certain illnesses or disease manifest differently in women from men.
Absolutely.
How does that work?
So, for example, if you look at people that have chest pain, have one of these angiogram tests, okay, out of 100 people that have that test to look at the chest pain, 75% will be men who have the cholesterol blockage, only 25% women. But the other condition I talked about, where you don't have major blockages and you still have the same chest pain, then you're talking about 60-70% are women, and only 30% are men. So you can see that women are more likely to get problems in the microscopic blood vessels. They can get both, but they're a little bit more likely to get that, whereas men, we seem to more often get the cholesterol blocks. And so that's different. Again, you can get both, but in both genders, but there's more prevalence, to the cholesterol blocks heart disease in the men.
Yeah, so I guess that's a confirmation that doing research only or mostly on men means that the women's health gets kind of set aside. But that's improving now, though. It's changing.
Yeah. So there are two problems there. One is appreciating that women can have heart disease with one of these angiogram tests being normal. That's one side of it. But the other side that's important, and like the Heart Foundation is particularly keen on promoting this, and there's also other groups, is that it's always thought if a woman has chest pain, that's a man's disease. It's more prevalent in men in their middle age, but women can certainly get it, and they need to, if they're getting chest pain, and if it gets going for half an hour, they need to get themselves to the hospital.
Now, from what I'm gathering, I guess you focus on the treatment and measuring once a disease has manifested itself, rather than prevention. But I'm sure you have lots to say about it. Because, for example, this morning I was reading an article about a study on a UK database, but also others that suggest that diet in the very early years of life has an impact. This study was about people who were born during the World War II with rationing in place. It's not particularly conclusive, but I've spoken a few times to Luigi Fontana in Sydney, and he plays a lot of evidence on food and diet for longevity and cardiovascular issues. Is that something that I'm sure you have focused on, probably not directly in your research?
You're right. No, not so much in my research, because it is a difficult area to research. But certainly in my treatment, as I'm looking after patients, that's a very important part. And probably the key thing which you alluded to before, the one solid evidence we have in terms of diet is the Mediterranean diet.
Yep.
That certainly seems to reduce cardiovascular events. And so that's something that, we should be promoting.
Okay, that's a nice segue, because when I spoke to Luigi Fontana, I discovered his father was from northeast part of Italy, and his mother's family was from Calabria. He said very different cuisines, very different climates, and he said, I myself in a genetic test, because all of his father's family died young with cardiovascular issues. So a bit of a morbid way of introducing the subject, but what's your Italianness?
My family, we're all Veneti. That's when I was working in Rome, I was known as the Dottore Australiano Veneto, because I speak more Veneto than proper Italian. But it was also, I learned a lot of Romano while I was there also, because of the influence from the local people there too.
So where in Veneto are the Beltrame?
So like on my mother's side, they're from Riese, and on my father's side, they're from Castelfranco, Veneto. Yeah.
Oh, okay. Cool. And have you moved towards a more Mediterranean diet from the Veneto style diet over the years?
Yes. We still have our polenta, of course, but yes, particularly enjoy the Mediterranean diet, and the balance between the greens, the fruit, and all that, I think is important. Yeah.
Cool. Okay. Well, thank you very much for having connected with Radio Italia Uno to talk about this, and congratulations again for the recognition of many years of high quality research in a very important area.
Thank you very much.